Morning, everyone. We are starting with the General Club today. Dr. Mahesh will give the background of the study.
Good morning, everyone. So today we discuss a General Club on a practical guide for assessing and managing cardiovascular risk during androgen deprivation therapy in patients with prostate cancer. Introduction: prostate cancer is among the most common cancer in males worldwide. An estimated 1,16 lakh cases and 3,66,000 deaths in annually. The critical role of androgen in stimulating prostate cancer growth was established in 1941 by Charles Hawkins. And androgen deprivation therapy is the cornerstone of systemic therapy for men with high risk, localized recurrent and metastatic disease because of the fundamental reliance of the disease on oncogenic androgen signal. ADT can be accomplished either by surgical orchiectomy castration or medical castration that using the GnRH agonist and antagonist. Other anti-androgen therapies in the form of androgen receptor antagonist and hexagonal testosterone synthesis, that is abiraterone CYP17A1 inhibition, that further decrease testosterone signaling and are used in conjunction with ADT agents. Drug used for ADT is LHRH agonist that include leuprolide, gozerelin, and triptorelin. LHRH antagonist that dagarelix, sevarelix, and relugolix. Anti-androgens, bicalutamide, flutamide, nilutamide, and second generation anti-androgen enzalutamide and new is apalutamide. Androgen pathway inhibitor CYP17A1 is abiraterone. Mechanism of action of a GnRH agonist is overstimulation of a GnRH receptor that leads to desensitization of receptor. But in first 2 to 3 weeks, that is a surge of hormone. And GnRH antagonists, relugolix and dagarelix, directly inhibit the GnRH receptors. There is a surgical castration by bilateral orchiectomy. Androgen synthesis inhibitors, abiraterone CYP17A1 inhibition in the adrenal gland. And first generation androgen receptor inhibitor, flutamide, nilutamide, bicalutamide on block the androgen receptor on prostate. And second generation that inhibit the androgen in the androgen in the cell. And that effect on the brain, heart, and vasculature or on pancreas that lead to patient develop ischemic stroke and other heart effect and vasculature endothelial or smooth muscle cell or pancreas that patient lead to develop diabetes mellitus. Common side effect of androgen deprivation therapy include hot flushes, loss of libido and erectile dysfunction, weight gain, decreased muscle mass, sarcopenia, accelerated bone mass loss, and increased risk of fracture and osteoporosis, mood disturbance, cognitive function decline, and altered metabolic profile. Increased cardiovascular risk. So, increased cardiovascular risk by dyslipidemia, sarcopenic obesity, and coronary artery disease like MI, or cerebrovascular disease, stroke, and transient ischemic attack, venous thromboembolism, and mimic metabolic syndrome. Baseline assessment before starting ADT is a patient history, cardiac disease, any cardiac disease, congestive heart failure, MI, and other vascular like hypertension, lipid abnormalities, or there is a diabetes, obesity, smoking, alcohol intake, and exercise history. Physical examination, laboratory with a metabolic profile, bone density and fracture risk assessment with nutrition assessment, and also advice for physical therapy and additional consideration like a drug therapy post statin and low dose aspirin or antihypertensive, diabetes or metformin. Possible reason for GnRH agonist related increased cardiovascular risk are low FSH suppression that facilitate atheroma formation and progression, monocyte and T lymphocyte activation, and potentially testosterone microsurges. Together, these actions may promote atherosclerotic plaque formation, disruption, and thrombosis. Androgen deprivation therapy they lead to change the level of circulating adipocytokines like leptin, resistant, and adiponectin, change in body composition, insulin resistance, and dyslipidemia that lead to development of metabolic syndrome. Or there is a T cell activation and destabilization of a fibrous gap in atherosclerotic plaque rupture, prothrombotic state that lead to cardiovascular disease. Low testosterone and high FSH that lead to monocyte transmigration, cytokine release, and resorption of calcified region and plaque instability. Pro-inflammatory T helper 1 cell are dominant in atherosclerotic plaque and the lymphocyte express GnRH receptor. And on activation by the GnRH agonist lead to T cell proliferation. T lymphocyte may cause atherosclerotic plaque rupturing through the release of pro-inflammatory cytokines and macrophage stimulation. And macrophages maintain the local inflammatory response, increasing plaque development and thrombosis. To increase cardiovascular disease risk with ADT treatment, so GnRH agonists were the first ADT agents available on the market and hence have the largest body of evidence for their cardiovascular safety. Keating et al. First reported increased risk of incidence of CAD and MI and sudden cardiac death in association with the GnRH agonist. Atherosclerotic cardiovascular disease is the leading non-cancer cause of death in a patient with a prostate cancer. GnRH agonists have been associated with significant adverse metabolic effect like increased central adiposity, sarcopenia, elevated triglyceride and LDL level, impaired glycemic control, reduced insulin sensitivity, increased inflammatory marker, arterial wall remodeling, and endothelial dysfunction. So studies have suggested that the excess of cardiovascular risk observed with the GnRH agonist is attributed to their impact on worsening the global cardiometabolic profile of these patients. However, mechanistic studies have further shown that the differential cardiovascular impact of this medication might also be related to the effect of hormonal changes in pre-existing plaque stability. Studies on GnRH agonists that is observed first is a Keating 2006 observational studies of GnRH agonists versus non-ADT treatment. So myocardial infarction, sudden cardiac death, and coronary artery disease hazard ratio is 1.12, 1.34, and 1.16. Phase 3 RCT, 4-month ADT versus long-term ADT. So long-term ADT increased cardiovascular event. Other is a ADT plus RT versus RT alone. That is a long-term follow-up of RCT. So in men with a moderate or severe comorbidity, treatment with the RT alone with a reduced cardiac mortality. Secondary analysis of RCT, ADT plus RT versus RT alone, there is no significant difference between ADT plus RT versus RT alone. GnRH antagonists, that emerging data mostly from secondary analysis of RCT or retrospective studies suggest that they had an improved cardiovascular risk profile with the GnRH antagonists. Meta-analysis was Crane et al. Included RCTs of GnRH antagonists versus agonists and demonstrated that the 45% relative risk reduction in cardiovascular event and 54% relative risk reduction in cardiovascular death favor of GnRH antagonist. Direct GnRH antagonist studies is a meta-analysis of RCT. So GnRH agonist versus antagonist. So cardiovascular event reduced in GnRH antagonist group, relative risk is 0.52. Leuprolide versus relugolix, that is cardiovascular event incidence was reducing the relugolix, and GnRH agonist versus GnRH antagonist. And there is a phase 1 RCT, 18.1% absolute risk reduction in of major cardiovascular events. There is a pronounced randomized trial, cardiovascular safety of degarelix versus leuprolide in patients with prostate cancer. A multi-center prostative randomized open-label trial, that is a man with a prostate cancer and concomitant atherosclerotic cardiovascular disease, were randomized 1:1 to receive the GnRH antagonist degarelix or GnRH agonist leuprolide for 12 months. The primary outcome was the time to first major adverse cardiovascular event to 12 months. Unfortunately, enrollment was closed early because of slow accrual with 545 out of 900 participants. The median age was 73 years, and major adverse cardiovascular event occurred in 15 patients assigned to degarelix and 11 assigned to leuprolide. Hazard ratio is 1.28. Although no strong conclusion regarding outcome can be drawn from the pronounced side, but because it was underpowered, one important assessment was clear that using cardiovascular guideline-directed secondary prevention strategies had a significant impact on reducing cardiovascular morbidity and mortality, similar to the general populations. Other is androgen receptor antagonist. For the systematic review, the androgen receptor inhibitor plus ADT versus ADT plus placebo, the increased rate of hypertension and cardiovascular disease noted with a combination of androgen synthesis inhibition and ADT compared with ADT plus placebo. So this risk optimization with well-established therapies, including lifestyle modification, guidelines recommended statin use, and blood pressure lowering medication, among others, not only reduce the risk of subclinical cardiovascular disease progression, but has a significant role in minimizing the risk of acute event for those patients with a pre-existing disease. However, recognition by the oncologic treatment team of the excess cardiovascular risk is crucial and should encourage the regular referral or communication with the primary care providers. Thank you.
Thank you. Thank you, Mahesh, for giving the background. Now, let's go to the further parts of this article. Dr. Manshu, like to share the screen? Yes, the screen is well visible. You can unmute yourself and start.
Good morning.
Good morning.
Am I audible, sir?
Please go ahead.
Good morning. Today's topic of our discussion is a practical guide for assessing and managing cardiovascular risk during ADT, that is androgen deprivation therapy in patients with prostate cancer. Prostate cancer remains the most prevalent malignancy among the men globally, and androgen deprivation therapy is a cornerstone in its management. However, the cardiovascular risks associated with ADT present a critical challenge, necessitating a comprehensive understanding and meticulous assessment strategies. My discussion will span over the three pivotal areas. They are methodologies for assessing cardiovascular risk. Second is role of coronary artery calcium in risk stratification in patients of prostate cancer. The third one is inherent challenges of cardiac risk assessment, which is concomitant in patients with CA prostate. Moving forward for the first topic, it is how to assess the cardiovascular risk in patients who are starting androgen deprivation therapy. There is a comprehensive cardiovascular evaluation which is needed. The initiation of androgen deprivation therapy in patients with prostate cancer requires a thorough cardiovascular risk assessment due to the increased risk of cardiovascular events which are associated with the ADT. A standardized approach to this assessment is crucial for identifying patients at elevated risk and implementing the appropriate risk mitigation strategies. In clinical atherosclerotic CVD screening, the foremost important thing is detailed history and physical examination of the patient. The initial evaluation should include a history and the signs and symptoms of the patients which are suggestive of atherosclerotic cardiovascular disease. This includes angina, claudication, exertional dyspnea. And we should also look for the physical examination. If the patient has the blood vessel thickening or the patient has xanthal asthma, we should look for it. Then the investigations, the preliminary investigations which we should focus are ECG of the patient, CT coronary angiograms, invasive angiography, and arterial duplex studies. They should be promptly conducted if the symptoms are present, and refer to the cardiologist or other specialist are essential when the significant findings are observed. Moving forward for the next topic, that is essential 8 components of cardiovascular health. The American Heart Association lists 8 essential metrics. They include healthy diet, physical activity, nicotine avoidance, healthy sleep, lipid control, BP management, weight management, and glycemic control. Particular attention should be given to the patients who are younger than 65 years of age, where a family history of premature onset of cardiovascular disease can provide additional insights into the genetic predispositions. Moving forward to the 10 years ASCVD risk score calculation, utilizing risk prediction tools such as pooled cohort equations is essential for estimating the 10-year risk of ASCVD. For instance, let's say a typical 65-year-old man with hypertension and who is on blood pressure medication and average cholesterol level may have a 10 years ASCVD risk of 16.6%, placing him in an intermediate and high risk category. On the contrary, if the patient of the same age and he's not on a blood pressure medications with the same average cholesterol level, he will be put in a low risk category. So this calculation aids in stratifying the patients for more intensive cardiovascular monitoring and intervention. The parameters which are getting calculated during this risk calculator, they are age, diabetes, if the patient is diabetic or not, the sex of the patient, is a smoker or not, the total cholesterol and HDL cholesterol, what is the systemic blood pressure of the patient, is he on any treatment for the hypertension, and the race. Challenges in the cardiovascular risk screening and treatment. Despite the simplicity and critical importance of cardiovascular risk screening, it is frequently underperforming clinical practice. Data from the radical PC study and analysis of US veteran studies with prostate cancer revealed that a significant proportion of patients have poorly controlled cardiovascular risk factors, underscoring the need for systematic and rigorous screening protocols. The radical PC study findings showed that 2/3 of the men with prostate cancer are at high cardiovascular risk, with 99% having at least one poorly uncontrolled risk factor and 51% have more than 2 risk factors. This highlights the necessity for improved integration of cardiovascular risk assessment into routine oncologic care. Veteran study analysis, among the US veterans, only 68.1% received comprehensive cardiovascular risk factor assessment, and 54.1% had uncontrolled risk factors. This gap in care must be addressed through the better coordination between oncology and primary care providers. The next topic is the role of coronary artery calcium assessment. Importance of coronary artery calcium in risk stratification. The CAC assessment has emerged as a pivotal tool in redefining the cardiovascular risk stratification, particularly for patients who are getting initiated on ADT. The presence and extent of the CAC can significantly impact the clinical decision making and risk management strategies. The CAC assessment methodology is typically done by using CT scan, which many prostate cancer patients undergo for staging purposes. The Agatston scores derived from these scans quantifies the extent of calcification and correlates it with the cardiovascular risk. The scores are categorized as 0, 1 to 100, 101 to 400, and more than 400. With score more than 100 indicating a high risk of atherosclerotic risk that warrants statin therapy. The prevalence of coronary artery calcium in prostate cancer patients. Studies indicate a high prevalence of CAC in men with prostate cancer. For instance, a single center study involving 211 patients undergoing PET or CT scan for recurrent prostate cancer found that 71% had CAC, with 1/5 exhibiting severe calcification. This underscores the need of routine CAC assessment to identify the high-risk individual. Clinical implication and cost effectiveness of this CAC. Statin therapy initiation. CAC scores more than 100 are associated with 10-year ASCVD risk of more than 7.5%, a threshold which is commonly used to initiate the statin therapy. These align with guidelines recommending statin use for primary prevention in high-risk individuals. While initial CAC screening incurs additional costs, but its use in high-risk patients is cost-effective in long term by preventing the cardiovascular events through early intervention and targeted therapy. Moving forward, challenges with the cardiac risk assessment in patients with prostate cancer. There are many shared risk factors and between the prostate cancer and ASCVD, which mainly include chronic inflammation, oxidative stress, obesity, and diabetes. However, current ASCVD risk calculators do not incorporate the additional risk posted by the cancer and ADT, leading to potential underestimation of true cardiovascular risk. Inflammation and oxidative stress. Both prostate cancer and ASCVD are categorized by the systemic inflammation and oxidative stress, which contributes to endothelial dysfunction and plaque instability. ADT exacerbates this condition, increasing cardiovascular risk. Obesity and diabetes. They are prevalent among prostate cancer patients and are significantly contributors to the cardiovascular risk. Effective management of these comorbidities is critical for reducing overall cardiovascular risk. Need for specialized risk prediction models. There is a clear need for large-scale studies that integrate cancer diagnosis and ADT into cardiovascular risk prediction models. This would enable more accurate risk stratification and tailored management plans for patients undergoing ADT. Interventional trials and cardioprotective strategies. Trials such as Radical PC2 and Replace CV are crucial for evaluating systematic approaches to cardiovascular risk modification. These studies will assess the impact of coordinated care involving cardiologists and oncologists on cardiovascular outcomes in prostate cancer patients. Practical challenges and access to care. In many real-world settings, especially in the rural areas, access to specialized cardio-oncology care is limited. Primary care providers and oncologists must be equipped with the knowledge and tools to manage the cardiovascular risk effectively in these patients, emphasizing the importance of comprehensive risk assessment and timely intervention. And mechanistic underpinnings of cardiovascular risk with ADT. The pathophysiology of cardiovascular risk in ADT. The mechanistic links between ADT and cardiovascular risk are multifaceted, involving metabolic alterations, hormonal changes, and direct effects on cardiovascular risk. Metabolic effects. ADT is associated with the significant adverse metabolic events, including increase in the central adiposity, sarcopenia, elevated triglycerides and LDL, impaired glycemic control, reduced insulin sensitivity, and increased inflammatory markers. These changes contribute to arterial wall remodeling and endothelial dysfunction, which are the key factors in the pathogenesis of cardiovascular disease. Next is hormonal changes and plaque stability. The hormonal alterations induced by ADT, particularly the reduction in testosterone levels, can impact the stability of atherosclerotic plaques. Studies have shown that ADT increases the inflammation and necrosis within the atherosclerotic lesions, which leads to the plaque rupture and subsequent cardiovascular events. The differential impact of GnRH agonist and antagonist. Emerging evidence suggests that GnRH antagonist may have a more favorable cardiovascular risk profile compared to GnRH agonist. GnRH antagonists directly inhibit GnRH receptors and reduce the release of FSH and LH, leading to more rapid and consistent suppression of testosterone levels without initial surge, which is seen with GnRH agonist. This differential impact may translate to lower risk of cardiovascular events in patients who are treated with GnRH antagonists. The next topic will be presented by Dr. Gautam. Thank you.
Thank you, Manshu. So, Gautam, I think this part is more practical so that we can utilize in the daily practice.
Good morning, everyone. Good morning, everyone. I'll be discussing ways to reduce the cardiovascular risk. So managing cardiovascular risk is important. Particularly for patients with prostate cancer undergoing ADT. So this discussion will be about comprehensive lifestyle changes, pharmacological management, and consideration for specific patient demographics such as the elderly and those with comorbid conditions. Coming to the lifestyle modification, the first is the dietary interventions. So these dietary regimens like plant-based or Mediterranean diets, so these are central to the cardiovascular risk reduction. The Mediterranean diet, characterized by high consumption of fruits, vegetables, whole grains, nuts, and seeds, coupled with moderate intake of dairy, poultry, and fish, and limited amount of red meat, is supplemented by the primary use of olive oil, which replaces saturated fats found in animal products. So this diet has been demonstrated to significantly lower cholesterol and improve the overall cardiovascular health. This diet also includes elements like omega-3 fatty acids from fish, which have anti-inflammatory properties, and also has antioxidants to combat the oxidation on the heart. The plant-based diet emphasizes that minimal consumption of animal products, focusing on plant proteins, which are associated with lower cholesterol products and reduced risk of heart diseases. Coming to the DASH diet, which is dietary approaches to stop hypertension diet, focuses on reducing the sodium intake and promoting the high consumption of fruits, vegetables, and whole grains, and is particularly effective for for management of hypertension. This diet emphasizes on low-fat dairy products and foods rich in potassium, calcium, and magnesium. By reducing the sodium intake, the DASH diet helps to lower the blood pressure and thereby reducing the risk of stroke and heart diseases. This diet's emphasis on fruits and vegetables ensures that a high intake of fiber is there, which is beneficial for the cholesterol management and overall cardiovascular health. Beyond basic dietary recommendation, individualized nutritional counseling can further optimize heart health. For example, incorporating specific foods known for their cardioprotective properties, such as avocado, nuts, or seeds, can enhance the benefits of Mediterranean diet. Additionally, patients may also benefit from personalized meal plans that take into account unique metabolic needs and preferences. Research indicates that certain bioactive compounds in fruits, such as polyphenols in berries and flavonoids in dark chocolate, have potent anti-inflammatory and antioxidant effects, which can further reduce cardiovascular risk. Coming to exercise and physical activity, aerobic exercises such as walking, cycling, and swimming, coupled with resistance training, are crucial. Flexibility and balance exercises are also beneficial, particularly for older patients. The recommended physical activity level is 150 minutes of moderate intensity and 75 minutes of vigorous intensity weekly. So regular exercise enhances cardiovascular endurance, strengthens the heart muscle, improves blood circulation. Resistance training builds muscle mass, which is important for maintaining healthy metabolism and reducing fat accumulation. And flexibility and balance exercises in elderly helps them to prevent falls, which is particularly important for those who are at higher risk of injury. Physical activity extends beyond the cardiovascular health, contributing to weight maintenance, improve mental health, enhance sleep quality, and increase energy levels. Additionally, exercise has also been shown to improve quality of life and reduce psychological distress. Exercise also promotes release of endorphins, which improve mood and reduce symptoms of depression and anxiety. It also helps to regulate sleep patterns, leading to better rest and recovery. Exercise also, so the increased energy levels from regular physical activity can improve the daily functioning and overall quality of life. Coming to the recent advances, tailored to exercise programs that incorporate both aerobic and resistance training are essential for all patients. For instance, high intensity interval training, which is HIIT, has been shown to improve cardiovascular fitness more efficiently than moderate intensity continuous training. Additionally, incorporating functional exercises that mimic daily activities can help in older adults to maintain their independence and reduce risk of falls. Coming to the weight management, uh, it should be assessed every weight should be assessed every 3 to 6 months for patients who are unable to achieve optimal weight through lifestyle changes. Pharmacological interventions such as GLP-1 agonists, which are semaglutide and liraglutide, are recommended. These agents promote weight loss by enhancing satiety and reducing the appetite, and they also have favorable cardiovascular safety profile. GLP-1 agonists work by mimicking the hormone incretin, which increases the insulin secretion and decreases appetite. These medications slow gastric emptying, which prolongs feeling of fullness after eating. Long-term use of GLP-1 agonists has shown to improve glycemic control in diabetic patients and reduce the risk of cardiovascular events. Other options for weight management include orlistat, which reduces fat absorption in the gut, and phentermine topiramate, which suppresses appetite and enhances satiety. These interventions are particularly beneficial for patients with obesity, a known risk factor for cardiovascular disease. Orlistat works by inhibiting pancreatic lipase, the enzyme responsible for breaking down dietary fats in the intestine. Phentermine topiramate combines an appetite suppression with an anticonvulsant, leading to greater weight loss than either drug alone. And these medications should be used in conjunction with lifestyle modifications for optimal results. Coming to management of lipid disorders, so statins such as atorvastatin, rosuvastatin, and simvastatin are integral to cholesterol management. They inhibit HMG coenzyme A reductase, an enzyme which is involved in cholesterol synthesis, thereby lowering the LDL cholesterol levels. Statin therapy is recommended for patients with 10-year ASCVD risk of more than or equal to 7.5%. Those with coronary artery calcium scores of 1 to 99, especially after age of 55, and those with coronary artery calcium scores of more than or equal to 100, regardless of ASCVD risk score. For patients with existing diabetes mellitus, the maximal tolerated statin dose is advised. Statins not only lower LDL cholesterol but also have anti-inflammatory properties which help to stabilize the atherosclerotic plaques and prevent their rupture. They may also improve endothelial function, reduce the oxidative stress, decrease thrombogenicity, and overall contributing to the cardiovascular benefits. For patients who are intolerant to statins, alternative therapies such as ezetimibe, which reduces cholesterol absorption in the intestine, and PCSK9 inhibitors like alirocumab and evolocumab, which lower LDL levels by increasing cholesterol clearance from the bloodstream. So ezetimibe works by inhibiting the Niemann-Pick C1-like-1 protein, which is a protein in the small intestine that reduces the amount of cholesterol absorbed from the diet. And PCSK9 inhibitors are actually monoclonal antibodies that increase the number of LDL receptors on the liver, enhancing the clearance of LDL cholesterol from the blood. These therapies are particularly useful for patients with familial hypercholesterolemia and for those who cannot tolerate statins. The development of novel lipid-lowering agents such as inclisiran, which is a small interfering RNA that targets PCSK9, is offering promising avenues for patients with refractory hypercholesterolemia. These agents provide long-lasting LDL reduction with fewer side effects. However, further trials are awaited. Coming to the management of hypertension, the SPRINT trial advocates a BP target of less than 130 by 80 mmHg for most adults. First-line therapies include ACE inhibitors like lisinopril, enalapril, ARBs like losartan, valsartan, thiazide diuretics like hydrochlorothiazide and chlorthalidone, and calcium channel blockers like amlodipine and diltiazem. Beta blockers are used for patients with ischemic heart disease and heart failure. ACE inhibitors prevent the conversion of angiotensin 1 to 2, which is angiotensin 2 is a potent vasoconstrictor, and preventing its formation reduces the blood pressure. ARBs block the effect of angiotensin 2 at its receptor site, reducing vasoconstriction and aldosterone secretion. Thiazide diuretics reduce the blood volume by promoting excretion of sodium and water, which reduces the blood pressure. Calcium channel blockers relax blood vessels by inhibiting calcium entry into the smooth muscle of the heart, reducing the vascular resistance. And beta blockers decrease the heart rate and cardiac output, reducing the myocardial oxygen demand and blood pressure. In patients with resistant hypertension, combination therapy using multiple antihypertensive agents with complementary mechanism of action may be necessary to achieve target BP levels. This fixed dose combination pills also improve the compliance of the patient by reducing the pill burden on the patient. Advances in antihypertensive therapies include drugs like sacubitril valsartan, which combines a neprilysin inhibitor with an ARB to enhance the natriuretic peptides and improve the BP control. These agents offer additional benefits such as reducing cardiac remodeling and improving outcomes in heart failure patients. Sacubitril valsartan has been shown to provide superior BP control and reduce the risk of heart failure hospitalizations compared to standard ARB therapy alone. Coming to the management of diabetes, metformin remains the cornerstone of type 2 diabetes management due to its ability to improve insulin sensitivity and to reduce hepatic glucose production. For patients with established ASCVD risk, GLP-1 agonist and SGLT2 inhibitor should be considered early due to their favorable cardiovascular profile. Metformin activates the AMP protein kinase, which helps to regulate glucose and lipid metabolism. GLP-1 agonist, as we have seen the mechanism of action again, leads to weight loss and improved glycemic control. SGLT2 inhibitors reduces the glucose reabsorption from the kidneys, leading to glycosuria and lower blood glucose level. They also reduce the blood pressure and have been shown to decrease the cardiovascular mortality. Diabetes management should also include lifestyle modifications such as dietary changes, physical activity, weight loss, as we saw before. Regular monitoring of blood glucose level, HbA1c, BP, lipid profiles is essential for preventing complication. Multidisciplinary care involving endocrinologists, dietitians, diabetic educators, and cardiologists can optimize the outcomes for the patients. Now, coming to the personalized diabetes management, the advent of continuous glucose monitoring systems and insulin pumps allow for a more precise glycemic control in diabetic patients. These technologies enable real-time management of diabetes, reducing the risk of hypoglycemia and improving the overall glycemic management. CGM systems provide continuous feedback on glucose level, helping the patient and healthcare providers to make informed decisions about diet, exercise, and medication adjustment. Coming to tobacco cessation, the behavioral and pharmacological interventions include the behavioral and pharmacological interventions together are the most effective way of tobacco cessation. Behavioral therapy includes counseling techniques like cognitive behavioral therapy, which is CBT, and motivational interviewing. Pharmacologic options include nicotine replacement therapies like patches, gum, lozenges, inhalers, nasal sprays, as well as non-nicotine medications like bupropion or varenicline. CBT helps patients to identify and modify patterns and behaviors related to smoking, while motivational interviewing enhances motivation to quit by resolving ambivalence. NRTs provide a controlled dose of nicotine to reduce the withdrawal symptoms and craving, easing the transition to complete cessation. Bupropion is an atypical antidepressant that reduces the urge to smoke by inhibiting the reuptake of dopamine and norepinephrine. These interventions significantly improve cessation rates. Providers should strongly recommend cessation and provide comprehensive support to the patient. Relapse prevention strategies such as coping skills and stress management techniques can also help the patient to remain smoke-free. Integration of digital health technologies such as mobile apps and telehealth platforms can help in tobacco cessation efforts. These tools offer personalized support, real-time feedback, and remote monitoring, which improves further adherence to the cessation programs. Coming to the role of pharmacogenomics in tobacco cessation, understanding the genetic factors that influence nicotine addiction can lead to more personalized and effective treatment. Pharmacogenomic testing can identify patients who are likely to benefit from specific pharmacological interventions such as NRT or bupropion. Genetic variation in enzymes such as CYP2A6 can affect how quickly nicotine is processed in the body, influencing addiction severity and treatment responses. Coming to the reducing or abstaining from alcohol is also advised, as any level of alcohol intake increases cardiovascular risk. Studies have shown that even a moderate amount of alcohol consumption is associated with increased cardiovascular risk. Providers should counsel patients and the risk associated with alcohol consumption and encourage reduction of alcohol intake or cessation of alcohol intake. Cannabis use has been linked to cardiovascular toxicity through increased myocardial oxygen demand, sympathetic nervous system activation, and potential coronary vasospasm. Stimulants like cocaine and amphetamine elevate cardiovascular risk, causing hypertension, tachycardia, arrhythmia, and can trigger MI. Screening for cannabis and stimulant use is essential with appropriate counseling and cessation recommendation in high-risk patients. Combining behavioral therapies with medications such as naltrexone and acamprosate can improve outcomes for patients with alcohol use disorder. This medication reduce the cravings and rewarding effects of alcohol, supporting abstinence. Now, routine screening for substance use, including cannabis and stimulants, should be integrated in primary care visits. Providers should use validated screening tools and follow up with brief interventions and referral to specialized care as and when needed. The use of standardized screening tools for alcohol use disorders, such as the audit test or drug abuse screening test, which is the DAS test, helps us to identify patients at risk for substance use disorders. Coming to recent advances for cardiovascular risk reduction, the use of advances in wearable technology such as fitness tracker and smartwatches allow for continuous monitoring of vital signs, physical activity, and sleep patterns. These devices provide valuable data for managing cardiovascular risk and tailoring interventions to individual needs. Telehealth and remote monitoring technologies enable continuous monitoring of patients' health status, facilitating early detection of cardiovascular events and timely intervention. These technologies can improve adherence to treatment plans and reduce the need for frequent in-person visits. Coming to the last topic, which is special consideration for optimizing cardiovascular risk in elderly and frail patients. Screening for frailty using tools like frail scale or clinical frailty scale is crucial. Frailty significantly impacts the cardiovascular risk factor. Providers should incorporate frailty assessment into patient visits to ensure appropriate referrals to geriatric clinics for interventions such as exercise, nutrition, and medication adjustment. The frail scale assesses fatigue, resistance, ambulation, illnesses, loss of weight, and thus provides a simple and quick evaluation of frailty status. The clinical frailty scale, based on clinical judgment, ranges from 1, which is very fit, to 9, which is terminally ill, and helps us to guide treatment decisions and care planning. These assessments inform treatment decisions, ensuring that they align with patients' overall health status and goals of care. This is particularly important for older patients and those with multiple comorbidities, where aggressive treatments may not be appropriate. Palliative care and supportive care options should also be discussed with the patient, and especially with those patients with advanced frailty and limited life expectancy, to optimize the quality of life and symptom management. Managing cardiovascular risk in elderly and frail patients requires a multidisciplinary approach involving cardiologists, geriatricians, dietitians, and physical therapists, and social workers. Regular team meetings and care coordination improves communication among healthcare providers and ensures that all aspects of the patient care are addressed. For frail patients, interventions should focus on improving physical function and reducing the risk of adverse outcomes. Exercise programs tailored to frail individuals, such as those emphasizing balance and strength training, can help them to improve mobility and reduce the risk of falls. Nutritional interventions, such as ensuring adequate protein or calorie intake, helps them to prevent muscle wasting and improves the overall health. Medication reviews and de-prescribing protocols can help elderly people to reduce the burden of polypharmacy and minimize the risk of adverse drug events. Cognitive and emotional health is also integral to overall well-being of the elderly patients. Regular cognitive assessments and screenings for depression and anxiety should be a part of routine care. Interventions may include cognitive behavioral therapy, social engagement activities, and medications when necessary. Cognitive stimulation therapies such as memory exercises and puzzles help to maintain the cognitive function in elderly. Social engagement activities such as group exercise classes and community events helps to reduce the feeling of isolation and improves the mental health. Coming to the hypertension management in elderly. So older adults are at a higher risk for postural hypotension, which can increase morbidity and mortality. Antihypertensive treatment should be closely monitored for symptoms of hypotension, with adjustment made as and when necessary to prevent orthostatic hypotension. Careful selection and titration of antihypertensive medications is essential to prevent complications. In older adults, aggressive A1C target should also be avoided to reduce the risk of hypoglycemia, particularly in those with reduced functional status. a less aggressive HbA1c target of 7.5 for patients with intact cognitive function and 8 for patients with poor cognitive or functional status are advised to minimize the adverse event of hypoglycemia. However, individualized treatment plan should consider patients' overall health, comorbidities, risk of hypoglycemia, aiming for a reasonable glycemic control without undue risk. While statins, coming to hyperlipidemia in elderly, while statins are known to reduce adverse cardiovascular outcome, their benefits in older adults remain unclear due to limited prospective data. However, retrospective analysis suggests that there are benefits, but it necessitates but a careful balance between potential benefit and risk of drug-related side effect is necessary in elderly population. For older adults with elevated cardiovascular risk and longer life expectancy, statin should be started at the lowest possible dose and then titrated up very slowly. Hydrophilic statins like rosuvastatin and pravastatin are preferred for those reporting cognitive changes with statin use. Regular monitoring of liver function test and muscle enzymes is recommended to detect and manage potential adverse events. For statin intolerant patient, alternatives like ezetimibe and PCSK9 inhibitors or bempedoic acid should be considered. Bempedoic acid is a newer agent which inhibits ATP citrate lyase, an enzyme which is involved in cholesterol synthesis and can be used in combination with other lipid-lowering agents. Now, coming to the last point, statins, there were concerns about statins increasing the dementia risk, however, this has been refuted by the recent studies. A systematic review and meta-analysis found that statin use is associated with a reduced risk of dementia and Alzheimer's disease, with no significant difference between lipophilic and hydrophilic statin. High-potency statins were found to be more effective in reducing the risk compared to low-potency statins. Despite patient-reported cognitive side effects associated with statins, switching to hydrophilic statins is not recommended because there is no prospective data for the same. To conclude, advancement in prostate cancer therapy and screening have markedly reduced the morbidity and mortality. The cardiovascular disease has emerged as the leading cause of death among prostate cancer patients, requiring vigilant cardiovascular risk management. This comprehensive analysis highlights the pivotal role of oncology care team in screening for cardiovascular risk factors and collaborating with primary care providers to implement effective risk reduction strategies. Further, leveraging technological innovations and embracing a multidisciplinary approach can enhance the effectiveness of cardiovascular risk reduction strategies and ensures a holistic approach to patient care. Thank you.
Thank you, Gautam. So first, I would like to ask if anybody is aware of the ACVD risk estimator. Gautam, what do you think? Are you aware of this ACVD risk estimator? I think during medicine training, most of us would have utilized it.
Yes, sir. Yes, sir.
Yeah. So this is a very simple tool which is available online. And if you see, we enter a case of around a young prostate cancer, 58-year gentleman who is non-white, non-African, non-American, others. And if you enter the blood pressure, which is the routine, usually we see 140/90, the most common blood pressure. Then you have to enter the cholesterol. So most of the things are very simple. These can be done by the nurse or one of the coordinators. SDL cholesterol is mostly below 15 in Indians, and most are diabetics, most are smokers, and most are treatment of hypertension. This is what happens in a prostate cancer patient of around age 50 to 60 years. So if you see the recommendation, if you see this recommendation is saying that statin initiation is indicated in the context of clinician-patient risk discussion. Statin intensity may depend on the presence of additional risk factors. It is reasonable to add ezetimibe in this patient to reduce LDL-C as well. So it is accordingly we can add. if you see 10-year ASCVD risk calculated is 44%. So in a 55 to 60 years patient of prostate cancer, which we see a lot, young prostate cancer are much more common in our country, I think, than any other, than the Western world. And lifetime ACVD risk calculated is 69%. But if we improve it, we can reduce it significantly, because these are mostly modifiable risk factors. So counseling for stopping smoking, counseling for diabetes control, management of lipids. These are some basic things which are important. So when a patient is on follow with ADT, the patient is on hormone sensitive prostate cancer or CRPC, but well controlled, not only on ADT, you need to understand that just doing a serum PSA is not enough. You need to do the required workup, including HbA1c and lipid profile, which we have learned for germ cell tumors as well. Because germ cell tumors also in young patients, there are high chances of cisplatin-induced metabolic syndrome in later age. So this is the same thing in ADT. In older patients, also we need to be careful. Involve your cardio-oncology team. So now a radical PC study, which was discussed during the introduction part and also during the part of discussion. So the radical PC study has the initial enrollment was completed. Now the study is being expanded, and TMH Mumbai, TMH Varanasi, and St. John's Bangalore. These are 3 additional centers which will be participants in this study. This is a UK funded study, and it will, in the radical PC study, it will be just an observational study of identifying the risk factors and what are the cardiac outcomes in these patients who are long-term ADT. At the same time, there is a radical PC2 study, which is an interventional study in which patients will be given intervention for reducing the lipids, also having the resistant training. So various physiotherapy interventions will be also be given. So these small studies, though are small, but actually have a significant impact on the patient outcomes, because we see a lot of patients of prostate cancer dying not due to prostate cancer, but due to other morbidities, including cardiac risk. So cardiac morbidity and mortality is very important in prostate cancer, because these patients are already older patients and having significant risk factors. And ADT is one of the additional risk factors actually, which is known to have increase in the cardiac risk. So patients who are at actually high cardiac risk, there is some data, I will not say it is mandatory. There is some data that GnRH antagonists are somewhat better than GnRH agonists, and even surgical castration. So some meta-analysis have suggested that, but there is no head-to-head direct comparison, which is also not possible actually. But this is the data which has come up from various meta-analysis and the. So the summary is that be aware of the cardiac risk factors, and just don't see PSA, because we need to treat the patient in total. We are not treating prostate cancer itself. We are treating the patient. So be aware, and be aware of these important small points which might make a significant difference in the outcomes of your patients. I will request the comments from Vanita ma'am, if she would like to make a comment on this ASCVD part or cardiac risk factor part.
Hi, Akash. Yeah, I'm here today. Sorry, I've been MIA many times. So this ASCVD risk calculator, first my question is, what you have shown us is American risk calculator. I think to the best of my knowledge, we have an American calculator, UK calculator, Chinese calculator. We have nothing for Indians. And Indians get clubbed into other, which is like rest of the world types. So I think this is somewhat of a glaring issue for us. My second question is, do we have an algorithm? So what is being followed in that study that you were talking about? Because what this, calculator and interventions, this is huge. I mean, I know you said it is simple and can be done, but if you start to do all of this and do the, your calculator, lipid panel, HbA1c, then maybe the CT scan calcium score, then whatever, exercise, smoking cessation, statin, all. I mean, it's a huge thing, right? So what do we have an algorithm? What is the basic minimum we need to do for all patients?
Yes, ma'am. As a part of this study, actually, we have some minimum requirements. CT scan based coronary artery calcification, though it's has shown some benefit in terms of calculation, we do not utilize it, and that is not mandatory for the study perspective as well, ma'am. So that is out. So the patient does not require any additional invasive test. Is not. We want to reduce interventions which are not mandatory, so
Okay.
we do not utilize it. So it is diet, physiotherapy, and cardio-oncology consultation. These three are the basics of that. And whenever the patient is being started on ADT, the patient will, the coordinator will help the patient to, coordinator will fill this calculator itself. This is a simple calculator. So, and the patient will be shown to a cardio-oncology physician, and the cardio-oncology physician and the medical oncologist will jointly discuss for the final plan for such patients.
Okay, so I think that is in the trial setting. In our clinical setting, there are so many patients who get started on ADT. So it just adds to the burden of our clinical work. So we know that this reduces toxicity, or that's what we are trying to find out through the study. I guess logically it should.
Yeah, when there is data from the radical PC study already that 66% patients have significant cardiac risk factors already. And this study is being now expanded, and India is a part of the study now. Yes, ma'am.
No, totally granted. So all of them will have cardiovascular risk factors. The question is, it is a competing risk of death, right? So question is does prostate cancer,
Yes.
is that in, because all of this, when you start lifestyle modification, my understanding was it takes 10 to 20 years to actually have an effect. So, but maybe this is a very old concept. I don't.
Ma'am, you got muted. Ma'am, you got muted.
Sorry, I got a phone call.
Yes,
I'll
ma'am.
just join back. Now you can continue discussion. Dr. Banat is calling me, and
Okay. So I will request Amit Joshi sir for his comments, because we have learned to do the follow-up of germ cell tumors patients, specifically from Amit Joshi sir, where he highlighted the important aspects of doing not only a simple AFP beta hCG LDH on germ cell tumor follow-up, but to look for the other important risk factors for long-term toxicities and metabolic syndrome. So similar concept will definitely apply here as well. So, Amit Joshi sir, your comments and the importance in an older patient.
I think you have chosen a very, very important topic. And we all know that with the newer and newer therapies, the long-term survival for even a metastatic patient. So if I ask any one of the region, what is the median OS for a low volume metastatic the prostate cancer and high volume metastatic, though, but we call it MHSPC, low volume and high volume metastatic. What is the median OS with the current available data? Anyone can answer this question. Who has presented the case today? The journal, I think one of them can.
Yeah, Manshu, Gautam.
That will give you the
From
idea
P1
that
trial,
why.
Can you help?
Piece 1 trial, what is the for the
Yes.
darolutamide, the Arasense study, or
Yes.
in fact they charted, and that is also a decent number if we can achieve the. Any
Yes,
guess?
5 years, sir?
Yeah.
For low volume or high volume?
For high volume?
Yeah, and for low volume, it was not reached actually.
Yes, sir.
The median survival was not reached in that study. Please. Yes, sir.
So I think that means the patients of a metastatic prostate cancer is going to survive for a majority of the patients are going to survive for a sufficient duration. So that discussed in the previous last discussion that the second most common cause of mortality in a metastatic CA prostate cancer is the cardiovascular or some sort of a vascular events leading to death. And we don't want our patient, and most of the time these factors are reversible. So if the patient dies, progresses and dies because of the disease, we cannot, or we can do something, but not always. But in a modifiable risk factor, we have a different options, and that we can delay that. So if we improve the or decrease the cardiovascular mortality, indirectly we are increasing the overall survival for this group of the patient. So that means and we all know that as the Indian, they have a high risk of cardiovascular morbidity and mortality compared to the Western world population, and that starts 1 decade earlier compared to the European or Americans. So that means we are not only exposed to the cardiovascular problem genetically wise, and when the treatment of the prostate cancer, which involves the ADT, and in the metastatic prostate cancer, where the ADT is going to continue practically for till the patient remains alive, this factor will compound. So both the uh, increased cardiovascular the morbidity or mortality because of the underlying genetic type, and the second factor, so it's a compounding factor that is leading to the, and most of the time when the urologist used to follow this patient, they used to mostly ignore these aspects, and just as I can say, the only PSA and should have a lipid profile, sugar. These are good enough data that even a isometric exercise. So whenever we have a time and we need to discuss, at least we have started discussing regarding the need for maintaining the muscle strength in this group of the patients. Fortunately, the hot flashes, which is one of the most common sort, we have not seen that much hot flashes side effect, but I think the muscle mass, anemia, fatigue, that more commonly we see with the ADT. So I think just like a PSA, we should at least in a 6 month or a 1 year repeat lipid profile, sugar, and a BP monitoring. That should be a part of our follow up. And these, when we find any factor, either you can start the anti-lipid drugs on your own, or if you have some specific unit or you have the physician in your board, you can refer to them for the proper. So I think there is no doubt that. So that is the reason now the discussion in a metastatic prostate cancer is happening, whether to what we call as the intermittent ADT, because most of the patients in the current era, the recommendation is to continue ADT for till practically patient progresses. Or so now the discussion is coming down: can we cut down the ADT intermittently? What we call as a previously intermittent ADT. So intermittent ADT is having a resurgence in the management of metastatic prostate cancer. That do all patients need ADT for and that is because of the side effect associated with the ADT. So we must remember that ADT is good for the breast, and it is must for metastatic prostate cancer, but it comes with a bag of side effects, and some of them are which can be modifiable or reversible. That we have to remember, that all of them not, but definitely majority of them can be tackled if we know that, and if we can have a intervention at right point of time before the things go haywire. So recognizing this fact that ADT is a risk factor for other issues also, if we have that thing in mind, we can look for the other side effect associated with, and we can improve the quality of life and probably the longevity also in this book. Thank you.
Thank you, sir. Thank you, sir. So, Vanita ma'am, back to you, ma'am.
Sorry. So again, my question is, what I was asking is this: all these lifestyle modifications, statin lowering, to my understanding, takes 10 to 20 years. So does it actually impact these patients? Who I mean, however much our prognosis is improving, it is not going to 10, 20 years, right? So does it impact in the shorter term? So risk reduction to hota hai, but risk reduction in terms of decreased number of events.
So, ma'am, the question is completely valid. So, it is important to understand, though presently we are seeing the survivals, we are discussing 5 and 7 year survivals, it is not going to 10 or 15 years in most of the patients. Some exceptional patients might definitely survive for 15, 20 years, but those are exceptions, not the routine.
Awesome.
So
I think
whether
maybe
lifestyle modification will lead.
Sorry, go ahead.
Yes, ma'am. Whether Yes, ma'am. So whether lifestyle modification will actually lead to improvement in the overall survival of these patients, that is a question which is presently unanswered in especially metastatic setting.
Huh.
In
Yeah,
adjuvant
no,
and
no.
neoadjuvant settings, where we use
Oh, yeah.
no doubt, I think.
No, my question is not about improved survival. I think we have to get out of this mindset of improved survival. So somebody who has a heart attack or a stroke and has that's severe morbidity. So decreasing the number of cardiovascular events, in my mind, would be the goal of this, not survival. I mean, fatal,
Yes.
both are fatal ho sakta hai, but not all are fatal, right? So, I
Correct,
guess.
ma'am.
So,
Radical
because
PC2 study is trying to answer that only, ma'am. So that is
Okay.
the exact endpoint which you suggested. A reduction in cardiovascular events is the primary endpoint of radical
Okay.
PC2 study,
Yeah.
which is looking whether the metastatic patients, if we are doing interventions in terms of physiotherapy, in terms of diet, in terms of this and that, whether it is leading to reduction in cardiovascular events during the lifetime of the patient. Exact same.
Okay, because I think exercise and diet and all both theek hai, the patient will feel better regardless. But a lot of these pharmacologic interventions, they are tough, yeah, especially in the older patients, statins and the BP lowering and all, they are very difficult to manage. Everybody gets started on glimepiride, then they get recurrent hypoglycemia. It's at least whatever I've seen is very tough. And okay, last question
Yes, ma'am.
is all of these new drugs, ezetimibe, GLP-1 inhibitors, do they have any interaction with ADT or with each other, or because there's all of these new things, right? The appetite
Yes, ma'am.
suppressant and all, which are recommended in all of the recommendations we heard.
Yeah. So, ma'am, I think the list might be long, but practically the utilization will be mostly confined to the statins and ezetimibe-based treatments. Utilization of semaglutide is now approved by FDA for weight reduction, and that drug is trade name is Ozempic, and that was in the news for a long time for last few months. And since I follow, it's also
so hot,
the
but
stocks of
what
those
about in
companies
cancer patients? Do we?
By some people.
So in cancer patients, it's safe?
Yeah, ma'am. So ma'am, just for weight reduction, most of our patients have low appetite, and we are struggling to maintain the weight in most of the patients, except a few patients. I would not think that utilizing such these drugs will be directly directly utilizable in our patients. That is what I presently think, ma'am.
But some of our patients are overweight. Some of the prostate older men, they do seem a bit on the overweight side. So I think my specific question is drug interactions. They are safe, and do they have specific drug interactions? Because when we look at a PIM chart, the potentially inappropriate medications, these new medications are not part of it, right? They're too new, and we don't know. So do we have any data, any idea?
So,
or any of the residents, or
so ma'am, we most of the time tend to utilize the Medscape interaction checker, and in that I recently checked for semaglutide with ADT. It was not having any interaction. So with ADT per se directly, they don't have interaction, but what with the interaction with other concurrent medications, that definitely will depend on individual patient. So it's definitely not.
Okay, sorry. We have shot way over. My apology. That's all. And this was an excellent discussion. My request to Dr. Mishra, can you record this and put this on the YouTube video? Because this was really good.